not too removed from where you guys were. I'm very well aware it's May, and the OCAPs are over. Nobody really wants to talk about corneal dystrophies, but it is what it is. And also another caveat is when I first made this, it was a few years ago, the first version of it, and I just switched from a PC to a Mac, and I started using Keynote. And for those of you that use Keynote, it's a lot more as far as, you know, transitions and creative things you can do. So I went a little overboard with them. It's a little obnoxious, but it's a lot of effort to go back and change it. So it is what it is. All right, so corneal dystrophies. As far as just a few general rules or characteristics, there's usually a strong pattern of inheritance. They're just about always bilateral and symmetric. Little to no relationship to systemic or environmental factors. Usually they begin early in life, but they may not become apparent until later on. And then they're slowly progressive, and they get more pronounced with age. And that's kind of what a dystrophy is. All right, so this is the way it's going to work. I'm going to put a picture up. Someone's going to shout out what it is. So basically, on tests, you know, they're going to ask you to try to figure out what it is, and more often than not, they'll ask you the inheritance pattern. So for all of these, somebody shout out what you think it is. Tell me what you think the inheritance pattern is, and then I'll give you my little spiel about each one of them. And that way we'll get through them pretty quickly.
Snapshot.
Yeah. All right, so it's got a bunch of different names. Here, people call it anterior basement membrane dystrophy, or in your notes, you guys always write ABM changes. Where I trained, it was EBMD, so epithelial basement membrane dystrophy. Mapped out fingerprints, another name. Kogan microcystic epithelial dystrophy is another name. It's all the same thing. Anyone know the inheritance?
Dominant.
Most often sporadic, actually. It just kind of happens. You know, don't worry about the genes. If you're very gung-ho, you could try to memorize all of them, but that I don't think I've ever been asked about a single gene on a test yet. So if you look at the path, you'll see a thickened basement membrane. You'll get intraepithelial extensions of the basement membrane. Often the epithelial cells will have these microcysts in it. All right, it's very common. If you look hard enough, you'll find it in over 10% of the population, especially in women over the age of 50. And it sounds just like the name. So mapped out fingerprint, you'll see gray patches, fine lines, little microcysts. If you've ever done this in a dilated pupil, if you do retroillumination, these things show up really well. In general, to look for a subtle corneal finding, if the pupil's dilated and you retroilluminate, you'll see a lot of things you wouldn't see otherwise. As far as symptoms go, it's either from recurrent erosions or these things can cause subtle irregular astigmatism leading to blurry vision. And this becomes really important as far as when it's come time to do cataract surgery. So as far as the management goes, you treat the erosions, and in these special circumstances, you can remove, for lack of a better term, lesions. And we'll get into that in just a second. So as far as treating corneal erosions go, recurrent erosions, well, first of all, what is a corneal erosion? You have to have a history of a shearing injury, so like a fingernail or a tree branch or a paper cut, or a history of EBMD. These are the two types of patients that will get these things. And they'll come in with sudden onset eye pain, usually in the middle of the night or when they first wake up in the morning. And it could be very minor, and it goes away in 30 minutes, or it could be pretty severe, and it takes days and days for it to go away. Oftentimes, by the time they come in and see you in the ER, the epithelium looks completely normal. There is no frank defect. But, again, if you use this little retroillumination trick, you'll see subtle changes. You'll see maybe little epithelial microcysts in a certain area, or the epithelium may be swollen, and that could be a sign that something's happened there. And then I always look in the other eye for signs of EBMD. So as far as medical treatment for an erosion, all right, so what do? The classic teaching is, Muro 128 drops in ointment. And then what this does is it creates an osmotic gradient, and theoretically what it allows the epithelium to stick better to the underlying bowmans. That works, but you got to be on it for 6 to 12 months to really see any kind of effect. Miro burns too. Patients don't like it. BCSC says put them on a cycloplegic. Oftentimes the cycloplegia is worse than the actual erosion. If it goes away in an hour or a few hours and you put a drop of atropine in, they're going to be pissed at you because they can't read for a week now. So I'd be careful about that. What I normally do is I start steroids, usually FML 3 times a day, and I put them on it for a month. And then also I'll put them on doxy, usually 50 milligrams twice a day. And the thinking behind this is a lot of people believe that these erosions are caused by an increase in MMP activity. So both of these will reduce that activity in the cornea. And it's a quicker treatment than using Miro. And the patients feel better a lot quicker. That being said, just about everyone also in my clinic gets a contact lens. Makes them feel better a lot more quickly. And I just leave it on for 2 weeks. I put it on, give them an antibiotic drop, tell them to come back in 2 weeks. I take it off, I see what it looks like. And usually by that point, they're doing well and they're fine for as far as this episode goes.
If you did not place a BCL, would you cover with antibiotics?
Usually not. Yeah, if I just put them on a steroid, then I don't put them on an antibiotic. Unless there's like a huge epi defect, but still, sometimes I still don't.
At what point in the course of this does one start the Miro? I've seen people avoid it at certain points. If I were to go that way.
If I were to go that way, right away. Yeah. If you think if you're going to do Miro and you think it's recurrent erosion, just start it right there. Sometimes what I'll do is I'll do FML during the day and Miro ointment at night. Kind of get the best of both worlds. It's not really an exact science. It's kind of everyone has their own opinion about this sort of thing. And mine is try to get them to feel as better as quickly as possible with the least amount of treatment. Now, as far as surgical options, so let's say they keep getting this, you put a contact lens on and it keeps coming back. There's a few options. That's supposed to say anterior stromal micropuncture. That works really good in trauma-related recurrent erosion. So if someone had a tree branch injury or a fingernail injury and the erosion's peripheral, it works really well. You don't want to do micropuncture centrally just because it can cause some scarring. And it's really easy to do. I don't know if anyone's done this, but basically they sell these commercial needles that are bent at the tip, but you can very easily just do this yourself. Just take a needle driver, bend the tip of a 27 gauge needle, okay? And basically the reason you're bending the tip, and it's really blurry there, but the reason you're bending the tip is it's a safety net. So basically you're just stabbing the cornea, and if you bend the tip, you're not going to go all the way through. Although it's really hard to puncture the cornea doing this. You have to actually try to do it. I've never seen anyone do it. So, but basically just make little scratches in the cornea in the area of the erosion. First you take off any loose epithelium, okay? Get that all out of the way, and then just scratch up the cornea right there. For the first few days, you'll see the little lines in the cornea, but afterwards, after a few months, you can't even tell anything was done there usually. And the thinking behind this is you scar up the underlying Bowman's, and the epithelium heals and adheres to it better after that. Again, that works good for peripheral and trauma-related causes. Now, let's say you have an EBMD-related recurrent erosion, or it's central. In that case, I just do an epi-debridement. And if it's central, I don't polish Bowman's, but if it isn't central, if it's EBMD in the periphery, then I'll use a diamond burr and I'll polish Bowman's. It's kind of the same thinking as the stromal micropuncture, but it's a little less traumatic. But if it's central, I just debride the epithelium, and what I started doing is I started putting on a Procara. And the thinking behind that was it has these anti-inflammatory effects, so again, going back to the whole MMP thing, and it gets the epithelium to heal in a lot quicker. And this is what so going back to cataract surgery, a lot of times EBMD just goes unnoticed throughout a person's life, and it's completely asymptomatic, and they've been living with this for years and years and years. But they come in to see you for cataract surgery, and this is something you really have to look for, especially if you're going to put a multifocal lens in. I've seen a handful of people come in with a multifocal lens with central EBMD, and they're not at all happy with their vision. So what you have to do is you have to tell them beforehand that they have this problem, fix it, and then put the multifocal lens in. It's a lot easier to explain something beforehand than afterwards, and it just becomes a huge headache. And the nice thing, I know you guys don't think about this all that much, but our Procare reimburses really well. So just about any multifocal patient that has EBMD, I put a Procare on, and it works very, very well.
How does your debridement compare with the micropuncture versus the diamond burr? I think most of us see the diamond burr more often, or taking off a lot, and
So for a debridement, the way I do it is I just take a Wexel, and I just rub the epithelium, and whatever comes off, comes off. And then what I'll do is I'll take like a curved tire, and kind of the loose edges of it, I'll pick it up, and I'll just pull, and whatever wants to come off, comes off. So it's like I'm doing a capsulorhexis of the epithelium.
you could still do a large debridement with the anterior-stromal micropuncture.
Oh, yeah. I've done like a whole ring, basically, and I left just the central epithelium intact, and I punctured like a donut around it. So you can do a huge debridement as well. All right, so that's that. All right, what's this? It's a stromal dystrophy.
Granular?
Yep. All right, so how's... Ah, shit. All right, so how's all down there? All right, so granular. The way I like to think about this, first of all, it presents early in life. You get these crumb-like opacities. The key is they're usually central, so they don't extend to the limbus. And when you look at a dystrophy, you want to look for patterns. You want to look at where is it in the cornea, central or peripheral, how deep does it go, full thickness, anterior stromal, and then in between the lesions, what does the cornea look like? And in granular, the cornea and the stroma is clear in between these little crumb-like opacities, and there's other dystrophies where that's different. So very distinct crumb-like lesions. In between the lesions, it's clear. It slowly gets worse over the course of time, just like any dystrophy does. And the biggest issue with these are the erosions. Okay, so, and I did the last treatment for corneal erosions is PTK. I'm doing that less and less. It's more of a hassle to do that. You could fix just about anything in the office, whereas with PTK, you got to go to, if you don't have a laser in the office, you got to go to your laser center and this and that. But it works good in some of these stromal dystrophies, where if you want to actually clear the visual axis, you can use a laser, remove that corneal tissue, and if it's especially anterior, you can get people seeing better and avoid a transplant. But my stepwise approach, PTK, DALK, PKP, depending on how deep they go. And typically a transplant in granular dystrophy has a pretty good prognosis. As far as the path goes, the material in there is hyaline, and it stains bright red with Mason trichrome. I think I was on one of my OCAPs at some point, or one of the, there's a mnemonic, and one of the three was on there at some point. All right, so what's this one? That's stromal. It's not granular.
Granular.
Yeah. All right, so what's the inheritance of macular? Good. All right, so macular. I'd say it's the least common of the big three, granular, lattice, macular. This involves the entire cornea, so central and peripheral. Typically, they're clear at birth, but by the time they reach like 10, they've clouded over. You'll see these focal gray-white opacities. The edges aren't as distinct as they are in granular. And the key here is the stroma in between the lesions is cloudy compared to granular where it's clear. It can go all the way to the endothelium, so it involves the full thickness of the cornea. And typically these patients will notice a decrease in vision at some point between the age of 10 and 30. Same thing, treat erosions. Typically PTK doesn't work for this, the lesions are too deep, so PKP or DALK. But recurrences are more common in this compared to granular in the graft. Path. These deposits are basically glycosaminoglycans, and they stain with algin blue and colloidal iron. All right, what's this? Yeah, that one's easy. All right, so there's actually 3 types of lattice. BCSC really only mentions 2, so type 1 and type 2. I think it only mentions 2, at least my version only mentions 2. Type 1 and type 2 are autosomal dominant, both of them. Really the difference is the bottom left is type 1. I think the bottom right is type 1. And type 1 is really fine lattice lines, not associated with any systemic problems. And these lesions are more central. Type 2 is also called meritogia, I think. Yeah, meritogia syndrome. You have thicker lines here, and some of them progress to the periphery, so that would be the top left. And then you get systemic amyloidosis as well. So that guy in the top right has meritogia syndrome. I've never seen anyone that has that, but that's what it looks like. As far as path goes, so you get amyloid deposits most often in the anterior stroma. It'll stain pink with Congo red, that's the top right. And then it'll exhibit birefringence with polarized light, so it glows green if you look at under a polarized microscope. So that's the bottom right. Management's the same. So the management for all of these is basically the same. You treat the erosions, and then if it's affecting the vision, depending how deep it is, you either do PTK, DULC, or PKP. As far as lattice goes, recurrence is pretty common in a transplant. So as far as frequency, Meesmann's dystrophies recur the most, so Reis-Bucklers, then lattice, then macular, then granular. So as far as kind of, if you're going to do a transplant on someone, if you want to prep your patient as far as what the chance of this coming back is, that's a pretty good rule of thumb to follow. All right, what's this one? It's like it's a combination of 2. It's Avelino. I've never seen this in real life, but it's autosomal dominant. And again, it's basically a combination of the 2. You'll see these crumb-like opacities and these lines as well, so it looks like granular lattice. Management's the same. So as far as path goes, you'll see both. So you'll see hyaline deposits stained with Meesmann trichrome, and then amyloid deposits that stain with Congo red. So the top is the Meesmann trichrome, the middle is the Congo red, and then the bottom is the polarized. All right, so these are a little harder. What's this one? It's stromal. Starts with an S. What?
S.
Starts with an S.
Schnyder's.
Yeah. So Schnyder's Corneal Dystrophy. Anybody know the inheritance pattern? So if you don't know, most of them are autosomal dominant. So if it's on a test and you're going to guess, I'd probably guess autosomal dominant. Unless they're trying to trick you. And they're, I don't know. But most of them are autosomal dominant. All right, so this is rare. It's slowly progressive, and it kind of follows a predictable pattern. So when you're young, you get this central opacification. That's probably the top right there. And it'll get denser and denser, and by the time you get to the 3rd decade in life, so about the 20s, mid-20s, these patients will develop a dense arcus. The opacification kind of spreads to the mid-periphery in your 30s, and then eventually these patients get decreased corneal sensation. So everyone follows that same progression. The unique thing about this is it affects your vision in light, in bright light more so than in darkness. It causes a lot of glare in bright light conditions. Thinking is in dark conditions, the pupil dilates beyond the opacity, so you're able to see around it, basically. Just about all these patients get PKPs, often by the age of 50. And the other thing that shows up on tests is you want to check a lipid panel on these patients. A lot of them have abnormal lipids, and actually family members with normal corneas tend to have higher cholesterol levels as well. As far as the path for this goes, the opacities are actually accumulations of cholesterol and phospholipids, so you can use an oil red O stain. But if you just do a normal section and do H&E staining, it'll actually look like empty spaces, just like fat does. What's this? So that almost looks normal. So this is in the stroma. This one's kind of fake. Yeah? All right, this is Fleck dystrophy. It's autosomal dominant, and the reason I say it's almost fake because I've seen one patient with this, and I had to convince myself that there was actually something there. The corneas basically look normal, but if you look hard enough, you'll see these little tiny flat gray-white opacities. They're scattered throughout the stroma, central, peripheral, anterior, deep. The vision's normal, minimal symptoms. It can be asymmetric or even unilateral. So again, dystrophies are supposed to be bilateral and symmetric. This can be pretty random, and there's nothing to do about this. Yeah.
I had a patient that had flecks in both eyes, like those tiny snowflakes, and I sent them to cornea. She was totally asymptomatic, was just seen back for a routine exam, and someone diagnosed her with Fleck dystrophy.
Yeah.
I'm not sure who saw.
Yeah. There are some really rare dystrophies that, like Fleck is one of them. There's something called predecimate dystrophy, and I think posterior amorphous dystrophy. Those three patients have no complaints. Usually they're picked up on a routine eye exam. Nothing to do about them. And it just depends on the level of the opacity. So Fleck is everywhere. Predecimate is just in front of Descemet's membrane, and this posterior amorphous is in the back of the cornea. But yeah, it's probably Fleck. All right, what's this? This is epithelial. Mm-hmm. How's it inherited? Yep. All right, so if you look at this on path, these little microcysts are filled with PAS positive material. That's kind of a buzzword. These appear early in life. You get these little vesicles. Again, you can see it really well with retroillumination. These are retroilluminated images. You'll get a little bit of irritation, maybe a little bit of glare. Sometimes you get recurrent erosions in the cornea. But usually, it's not a big deal, and normally we don't treat these. I think I've seen one or two people with this, and usually a bandaged contact lens in the event of erosion is fine, and that's all you really need to do. Rarely, if the vision's really bad, can you do PTK to get rid of these. But even just an epithelial debridement often gets rid of them too. This one? Yeah. If anyone was at the dystrophy conference, there was actually a Lisch patient there. That was the first time I ever saw a Lisch patient, so that was pretty cool. All right, so what's the inheritance here? Yeah, this is I think the only one that's X-linked. So you get this feathery lesion. It's gray. It's limited to the epithelium. I've never retroilluminated it, but I guess you could see these little dense microcysts that make up this lesion. It almost looks like a cortical cataract of the cornea. Usually you don't have pain from these things. Sometimes you could have decreased vision. Epithelial debridement is a way to get rid of it just because it's localized to the epi, but they often come back. All right, what's this? It's the same thing at different points in someone's life.
Lattice.
Yeah. It's recessive. So these deposits are amyloid. Okay, so if you do this under polarized light, the whole cornea lights up green. The onset of this is first to second decade. Early on, it looks like Behnke, or I actually think that top right looks a lot like a Salzmann's nodule. But if you see something that looks like a bilateral Salzmann's nodule, I would think of gelatinous. Or you can get a clump of these nodules, and that's called a mulberry configuration. I think that's what that top right is trying to represent. You can get a pretty significant decrease in vision. I mean, look at the bottom right picture. That's called a kumquat lesion. So if you get to that, you're not going to be able to see out of that, so you need a transplant. Unfortunately, these often recur quite a bit, and these people need transplants over and over again, regardless of what you do. You could try PTK in the beginning, but usually you need to do a DALK or a PK, and it just about always comes back.
You saw this in your office and you weren't sure if it was like bilateral or Salzman appearing. It would have to have some family history of, like,
Usually because it's recessive, right? Yeah.
so that would maybe help direct your.
Yeah. But if it looked like a Salzman's, so you can do one of two things. You can remove it with the superficial keratectomy. I normally don't send Salzman's for path though, but if it comes back and it keeps getting worse, then you have your diagnosis. But yeah, if it looked like the top right, I wouldn't jump to a transplant right there. I would just kind of wait. All right, what's this? This is one of the Bowman's one. It's named after two people. Yeah. And it's autosomal dominant. All right, so this appears in the first few years of life. It affects Bowman's layer. You get these, it almost looks like granular dystrophy of Bowman's layer. So you get these coarse little geographic opacities. They start out centrally and then they extend all the way to the periphery at some point. The posterior cornea is completely normal. These patients get severe erosions. Eventually the cornea scars from erosion after erosion after erosion. And that's usually how the vision becomes compromised. The treatment initially, I would say PTK works pretty good for this as far as treating the erosions and clearing the cornea. But you can only do so much PTK and they always come back. So eventually these people usually end up with a transplant. Unfortunately, recurrence in the graft is very common too, so they may need multiple transplants. So this is Reis-Buckler's cousin. So what's the other one?
Thiel-Behnke.
Yeah. So Thiel-Behnke, it's very difficult to distinguish between the two just by looking at it in the office. It's the same gene, it's the same inheritance pattern. The onset's a little bit later in life, so it's first to second decade. They describe these things as sort of granular coarse opacities, honeycomb opacities. I guess if you use your imagination, it kind of looks like a honeycomb. It's less severe than Reis-Bucklers in general, so the erosions are less frequent, the vision's not as compromised. But again, people lose vision just because of clouding of the cornea. Treatment's the same. So how do you tell the difference? One, if you have tissue, this was on my OCAP, I think my second year, is what's the electron microscopy findings. So you'll get these curly fibers, that's a picture of that, and that's in Thiel-Behnke, and that's how you distinguish it from Reis-Bucklers. But what's kind of neat is, let's say you don't want to do a transplant, you don't have tissue, you can use confocal microscopy, and it's pretty, I rarely look at a confocal, so by no means am I an expert, but I mean I can tell the difference between the two. So the top right is Reis-Bucklers, the bottom left is Thiel-Behnke. You see more of this hyper-reflective focal deposition of stuff with Reis-Bucklers. And with Thiel-Behnke, it's more homogeneous, a lot less reflective. And this is at the layer Bowman's layer. So I don't know if you guys have looked at a confocal or done a confocal before, but basically it's a microscope that images layer by layer as you go deeper and deeper into the cornea. So you're getting kind of like a head-on view. So you'll start with the epithelium, go into Bowman's, and you just go layer by layer, deeper and deeper. And when you get to Bowman's, that's what you'll see. All right, what's this one? This is probably the second most common corneal dystrophy after EBMD. Yeah, this is Fuchs. All right, so, there's no known inheritance for Fuchs, but I always tell all my patients with Fuchs to have their family members get an eye exam because it definitely runs in families. You know, I've seen, a patient and their sister and their aunt and their cousin all have Fuchs. So there's got to be something there. I don't think they've found the gene quite yet, but there has to be some sort of family association. So if you ever see a patient with Fuchs, encourage their family members to get checked. It's also a nice way to get new patients in your practice. All right, so the first finding is corneal guttae. You'll first see them centrally, and then they'll spread out into the periphery. And then, as you guys know, as this progresses, Descemet's membrane gets thick. You get folds in the Descemet's, and then you get edema eventually. You'll often see endothelial pigment. Corneal thickness can get bigger and bigger and bigger. In later stages, you'll get epithelial edema with bullae, and this can become painful. And you want to get to them before they start to develop subepithelial fibrosis and stromal scarring, because the treatment for this now, as you guys know, is an endothelial transplant. And if you wait too long and you get stromal scarring, well, they're not going to clear and see nearly as well as they would have otherwise. Typically, onset is, age 40 to 50 to 60, but I have seen Fuchs patients with corneal guttae in their 30s. So there is an early onset variant. Typically symptoms, patients wake up in the morning, their vision's blurry as they go on throughout the course of the day and clears up. Some people figure out that when they're blow drying their hair, if they blow dry their eyes, the vision clears up. So that's kind of a home remedy for this. Other options, Mira 128 initially, but an endothelial transplant is the surgery here. As far as the path goes, you'll see thickens Descemet's membrane. The disease process here is a reduction in the number of sodium-potassium pumps as well as a dysfunction of the pumps. And then a little bit about specular. So if you do a specular on someone with Fuchs, you'll get something that is known as increased polymegathism and increased pleomorphism, meaning corneal endothelial cells are supposed to be the same size and the same shape. So if you have increased polymegathism and pleomorphism, there's an increase in the difference in the size of the cells and in the shape, of the cells. I'll show you a picture of this in a second. But where this becomes key as far as getting a specular is cataract patients. So if you have a patient that's having cataract surgery and you notice corneal guttae and you get a specular on them, there's certain numbers that have been established that indicate that there is a risk for corneal decompensation afterwards. So if the cell count's less than 1,000, or the corneal thickness is greater than 640, or if they already have epithelial edema, there is a chance or a likelihood that their cornea won't survive the cataract surgery. So these are the patients you may want to consider doing a combination DSEC or DMEC with their cataract surgery. Now this has changed a little bit ever since we started using the femtosecond laser. I just did someone last week that had a cell count of like 900 and a little bit of edema already, and I used the catalyst, and the next morning she was crystal clear. So I used zero phacotyme and I used Visco, and these patients can do quite well. Now she's young, she's like 60, so she'll probably need a transplant at some point in your life, but you bought her a few years. So the longer you can hold it off, the better off I think the patient's going to be. All right, what's this? This is endothelial as well. Yeah. The posterior polymorphous corneal dystrophy. This is pretty rare. I think I've only seen one patient with this, and that was as a resident. Autosomal dominant. As far as clinically, so in the cornea, you'll get these little vesicles in the posterior cornea. It almost looks like EBMD of the endothelium, is how I like to think about it, is how these things look. The other thing you'll get is you can get some correctopia and these iridocorneal adhesions, almost looks like high PAS. These patients get an angle closure and open angle glaucoma. About 15% of them come in with a high pressure. And the onset is pretty early in life, teens to 20s. Very similar to ICE syndrome, except ICE is unilateral, PPMD is bilateral, and then the treatment is PKP in severe cases. So here's a little specular. Sorry, top left is normal, all right? So the little cells look like hexagons. They're about the same size. They're about the same shape. That's probably what our speculars look like if we did it on us. Our cell counts are probably 2,600 to 3,000. Okay, that's pretty normal. Top right, what do you guys think that is? All right, so some cells are bigger than others. Some are hexagons, and some are circles, and some are triangles, so they're different shapes. Those little black things with the white dot in the center, those are guttae. So that's Fuchs dystrophy. That's early Fuchs. As Fuchs progresses, those little black spots get bigger and bigger and bigger, and that's where you have endothelial dropout. But that's someone who would, that picture right there is someone that would do still pretty well with cataract surgery. That's just early Fuchs dystrophy. Bottom left, what do you think that is? All right, so that's PPMD. And what you see there are those little vesicles. And then you get these little columns. The clicker doesn't work. I don't know if you can appreciate like that. They're the little bands in EDMD that you see on exam. So that's a pretty classic picture of someone with PPMD on a specular. And then this showed up actually on my OCAPs, I think my first year, but the bottom right, this was a really hard question. But the bottom right, what do you think that is? So maybe somebody said ice, but yeah, that's ice. So the finding in ice is something called dark light reversal. And what that means is typically if you look at the top left, the endothelial cells are white and the borders are dark. And if you look at the bottom right, the cells are actually dark and the borders are white. So that's kind of the classic finding in ICE syndrome. And that actually showed up in my OCAP. All right. Yeah.
Do we have a confocal here at Wells?
We do. No one's allowed to use it except Dr. Repuano, I think.
Where is it at?
It's in that room with the pentacam.
Okay.
Oh, wait. Oh, a confocal?
Or
A specular or a confocal?
specular.
Yeah, it's in that room. But, yeah, I'm not allowed to use it.
And then, any confocal?
I think we do. I'm not 100% sure, though. Hanish would know. Hanish knows the most about confocal here, I think. That I'm not sure. But there's definitely a specular. It's old, and it's hard to use. The newer ones are really easy. You just push a button, and it takes a picture. But if you, like in clinic, things are so busy that we don't really get confocals because you got to track down a technician and this and that. But with the newer machines, it's easier to do. But yeah, it's unfortunate because there is stuff to be learned.
Are you able to operate on the laser here?
The catalyst? Yeah, so I can use the catalyst. I'm not a proctor though, so I can't staff you guys.
What about for like a PTK or something?
Yeah.
I was thinking for like our rising class, that's kind of one way to do a refractive procedure.
Yeah. Yeah, it's covered by insurance too.
We could do the PTK for
Yeah, definitely. Yeah, for sure. All right, this is the last one. What's this? It's endothelial. It's in babies. Yeah, so this is CHED. So CHED, there's two. There's CHED 1, CHED 2, and this is just something you have to memorize. It's in a book. But CHED 1 is autosomal dominant. The way I remember it is CHED 1 is the better one to have. It's a stupid way to remember it, but it's a better one to have. It's not as bad. The symptoms are worse, so they do have photophobia and tearing. but the vision isn't as bad and the corneal edema isn't as bad. And sometimes these patients don't need surgical intervention, but CHED2 is recessive, and these people will come, or these kids will come in with corneas that are, almost 2,000 microns in thickness. They're huge, and they have nystagmus, and they can't see that well. They need a transplant. CHED patients, even though the disease is in the endothelium, you can't do a DSEC on them. You need positioning and things like that for a DSEC to work, so they all get PKs. All right, so I think we covered most of them. And I'm done.